Hello everyone, my name is Dr. Alex Milspaw. Happy to join you today, and I'm going to be joined by Dr. Liu here in just a moment, and we're going to talk about the effects of endometriosis on mental health, and certainly brain health when we're thinking of endometriosis as part of the inflammatory process of the body, and any systemic inflammation is going to lead to both GI inflammation as well as brain inflammation. And once inflammation is somewhere, then that can certainly change how it affects the neural nets and the nerves that it touches on. So Dr. Liu and I are going to talk about that and what it means and what PRM can offer for you today. So stand by as we wait Dr. Liu to finish up with clients and or patients today, and she'll be joining us any moment.
Hi.
Liz, hello.
Hi.
Welcome. Thanks for joining us today, Dr. Liu. I really have loved collaborating with you so far with patient care, and I'm hearing only good things. So I'm excited to share how we're collaborating with the world.
Awesome. Yeah. Can you hear me okay?
I can hear you perfectly. Yes.
Okay, great. Perfect.
So let's start out with kind of describing an overview of how would you describe endometriosis and the causes of it, and kind of your angle of what you look for, and we'll start with the medical side.
So, March is Endometriosis Awareness Month, and so there's probably lots of talk about endometriosis, especially since it's so closely related to pelvic pain and can be the cause of pelvic pain, and up to 80% of women who have chronic pelvic pain have endometriosis. Briefly, just the definition of endometriosis: it's endometrial-like glands and stroma that are found outside of the uterus. So just to be really basic, every month, if a woman's not pregnant, she sheds the lining of her uterus. That lining is called the endometrial tissue. And it's not that same tissue as what you're shedding during your period, but it's sort of like that tissue that is implanted. It's inside the pelvis. It implants, outside of the uterus. It can implant on the bowel, on the bladder, on the ovaries, on the fallopian tubes, on the uterus. It can be on the rectum. It can even be in the diaphragm. It can be on your lungs. It can be basically anywhere in the abdominal cavity. And it can cause a lot of pain, a lot of inflammation, because it's not supposed to be there. It's tissue that's not supposed to be there. So that, and a lot of times the tissue, the endometriosis lesions are, 1 millimeter, 2 millimeters. They're very, very tiny, which is why, if you go to the doctor or like to the GYN, they get ultrasounds, they get MRIs, they get CT scans, and it's not able to be seen on any of these fancy imaging techniques because it's too small. It's like looking for a pimple or a splinter, basically. It's not going to show up. Even in the world's best MRI machine, it's not going to show up. So unfortunately, a woman can be in 10 out of 10 pain. They have all these imaging studies, and it always comes back as, oh, there's nothing wrong with you. There's nothing. Your ovaries look beautiful. Your uterus looks beautiful. There's nothing wrong. And eventually, it takes an average of 10 years to get diagnosed with endometriosis. And over those 10 years, a woman's been in excruciating pain, told that she's totally fine, that there's nothing wrong. And so that's, that can really take a toll on their emotional health, on their mental health, because, there's something wrong. This is not normal to be in bed 3 to 4 days out of the week, or throwing up in pain, or calling out of work just because of your period. That's not normal, but you're told that everything's normal, everything's fine, there's nothing wrong with you. So that's why, especially endometriosis, pelvic pain, there's a lot of, it's not just a physical issue. It's a whole body, mental, emotional, issue that affects, it affects 1 in 10 women. And I actually think that number is underestimated, because 1 in 10 women is diagnosed, but think of the millions of women who are walking around out there who don't have a diagnosis, who are still being told, you're fine, there's nothing wrong with you. Your ultrasound and your MRI are completely normal. So I actually think it affects more than 1 in 10 women.
Yes, I absolutely agree. Certainly from, I think, what you and I have both seen in our careers so far, it's definitely there. Particularly just even listening to patients talk about their pain and the patterns of pain that we can see, even with bowel pain, right? So
Right.
when it's
Oh my God.
attaching in all these different places, the way it's and correct me if I'm wrong, the way it's causing pain is almost twofold. The way it's affecting the nerves and making the nerves more raw, more sensitive, but it's also the way it creates adhesions and scar tissue. It stops the connective tissue in the organs from being able to slide around the way they're supposed to. Is that right?
Absolutely. I mean, with really severe endometriosis, you, as a surgeon, you go in there and there's what we call it's what we call frozen pelvis, because everything is frozen. It's like rubber cement. Everything is just stuck. And so many of my patients will tell me, I just feel like something's stuck. Like I just feel like things are stuck together. And you go in, I go in there, I look around, I'm like, oh my gosh, yeah, your uterus, your ovaries, your tube should be like free and flapping in the wind. That's not the case with endometriosis a lot of times. A lot of times everything is so stuck. So yes, of course, that's going to cause a lot of pain. And like you mentioned, the nerve pain, endometriosis is it can cause inflammation in the pelvis. It's an inflammatory state. So it can cause a lot of nerve pain because those nerves are irritated because there's so much inflammation in the pelvis, and it can cause a lot of irritation to nerves. So you have this sharp shooting pain. You have, sometimes you feel like, burning or like things are on fire. And that's nerves. That's because endometriosis is affecting, it may not directly invade into nerves, although sometimes it does, but it can affect nerves because it's so irritating to them.
Absolutely. So you mentioned how endometriosis is basically a systemic inflammatory response, or one of the many that can happen. And I know when I see systemic inflammation in any way, but definitely with endometriosis, I'm assuming that it's affecting some of the inflammation that can also happen in the brain. Not that endometriosis is in the brain, but inflammation in one area of the body commonly creates inflammation in the brain. What's your understanding of that?
Yeah, no, you're absolutely right. It is a systemic, it causes systemic effects. And you're right, it's probably not in the brain, although I think there has been maybe a couple of reports of endometriosis in the brain, but that doesn't happen very often. So no, I don't think there's endometriosis actually in the brain, but it can cause brain fog, fatigue, joint pain. Some people will get, shoulder pain, joint aches, especially around, when everything else is flaring. And I'm like, I don't think you have endometriosis in your elbow. I don't think it's in your brain, but it's just that inflammation that's causing you just to feel just not good. And also when you're in pain all the time, you're not sleeping well, it takes a huge toll, not only mentally, but physically too. So yes, the fatigue, the brain fog, the mental toll that takes, as well as the physical toll that it takes is, it's huge. It's huge.
Yeah, and that's what I see. It's really bi-directional in that there's inflammation obviously with the endometriosis that creates the pain and the systemic inflammation, but the pain in of itself creates the stress response in the body, which also creates inflammation in the brain. But
right.
Then with the stress of the pain as well as the inflammation, then that creates its own changes in the brain, which then leads to some of the mental health issues that we see, such as anything that's related to chronic pain in general, as far as anxiety and the brain fog that you mentioned, difficulty concentrating and difficulty processing as many things, right? Difficulty multitasking, like people used to be able to multitask. Now it's really hard to kind of stay focused.
Right.
And I just see that correlation. And I also wonder, right, because as you said, some of these scans aren't showing up. The endometriosis isn't showing up on ultrasounds or CAT scans or MRIs, because it's either too tiny or it hides, right? I mean, I've seen fibroids hide. I've seen cysts hide on scans. And so is the only way to really rule that out would be going in, right? To really get in there with a laparoscopy and look around.
Yeah, I mean, that's really the gold standard of diagnosing endometriosis, going with a laparoscopy. Unfortunately, that requires a surgery. It's a big deal, surgery's scary, and I understand it's a huge step to take, but that really is the only way you can diagnose it. And the way you diagnose it is not just by looking inside with the laparoscope you have to remove the disease or excise it. You have to send that tissue to pathology. They have to look at it under microscope, and they have to be like, oh yeah, there's endometrial-like glands or stroma, that they see microscopically, and that's how you get a diagnosis. It's not good enough for a doctor to just look in and be like, yep, you have endometriosis, or it's not good enough for them to look in and be like, oh, that's called a diagnostic laparoscopy, where they just literally look inside and be like, yes, you have it, no, you don't, and then that's it. Because I've had a lot of patients who have had these laparoscopies where they're told they don't have endometriosis. And I'm like, okay, now what does the pathology report show? And they'll say, oh, they didn't take any biopsies. I'm like, well then, that's not enough information to rule in or out the disease. But yeah, and again, some radiologists, there's some really good radiologists who really are good at reading MRIs and ultrasounds, and sometimes they can pick up subtle disease that other radiologists are going to miss. I mean, everyone's different. Everyone has a different viewpoint. Some are better than others. So, sometimes the MRI reads are negative by one, and then you send it to someone who knows what they're looking for, and they'll be like, oh no, there's suspicion of an endometriosis lesion here in the rectovaginal septum, or so a lot of it plays into a radiology report and MRI. So when you say yes, it can hide, you're absolutely right. It can hide. The disease doesn't necessarily hide, but sometimes the radiologist may not pick it up because they're human, and they not be looking specifically for that.
Absolutely. And I think that's what I love, that you're pointing out not only the statistics of how common endometriosis is, at least from what we know, right? I think there's so many millions of women that aren't diagnosed that will most likely have it, but we can really look at the holistic symptoms that they have going on. So I saw a comment in the chat, if we see anyone with hypermobility, and I know in my career I've seen tons of, a high correlation between hypermobility and EDS, Ehlers-Danlos syndrome, with pelvic pain in general. But in that, you also see a lot of inflammation just from that. So again, I think when I'm talking to patients, really looking at what's their mental health, what is their brain function like, and what does that tell us about just the inflammation that's happening in the brain, but also their GI symptoms, right? If there's systemic inflammation and endometriosis, commonly there's irritable bowel syndrome in some way. Certainly the pelvic, the menstrual symptoms in terms of duration and heaviness and how intense is it. As you said, they're usually can't get off the couch for 2 to 5 days, if not longer. But also blood in their stools during their cycle, because the endometriosis can go in their stools. Is all that?
Yeah. Yeah. And I mean, these are just literally just the classic symptoms of endometriosis. With the bladder symptoms, the bowel symptoms such as bloating, gas, constipation right before their periods, blood in the stools, diarrhea with their periods, the IBS kind of, just that kind of, that bowel dysfunction. Again, bladder dysfunction, urgency, frequency. Sometimes there's blood in the urine only on their cycle or when ovulating. It affects every organ. It can affect every organ, really, in the abdomen, in the pelvis. It can even be in the lungs. It can be in the diaphragm, cause every time you have a period, you might have a collapsed lung, which is, terrifying, or shortness of breath, chest pain, right shoulder pain. But there's some women who have none of those symptoms. They have no pain with their periods. They have no pain with sex. They have no bowel symptoms, no bladder symptoms. Their only symptom is infertility, and they just can't get pregnant for whatever reason. And so that's another symptom too. And that's, there's a term called silent endometriosis, where there's really only, the only symptoms is the woman can't get pregnant, which is, but other than that, they don't have any other of the classic symptoms.
Yes. So with, as far as the pros and cons of surgery, and then how, wanting to talk a little bit about the Thriving with Endo course, and kind of the how and the why would addressing mental health issues or, calming the nervous system be useful for pre and post surgery? So I want to get to that, but in the first, why would someone sign up for surgery?
So generally surgery, most of my patients who want to undergo surgery just for, they want to get a diagnosis, they want to get confirmation. Many of them have tried birth control pills, IUD, medications, pain medication, heating pad, acupuncture. They've tried a lot of non-surgical management of their, either of their pelvic pain or of their dysmenorrhea or painful periods, and their quality of life is still not very good. So at that point, I do think that a lot of them are kind of at the end of the rope, and they just want to have surgery just to see what's going on. If there's endometriosis, to remove those lesions. And I usually, if you're having painful periods, but you're on birth control pills and you're living your best life, your quality of life is great, you're not having to miss school, you're not having to miss work, you're like living your best life. At that point, I wouldn't necessarily be like, yeah, let's do surgery. Because if you're doing well, fine, keep doing what you're doing. It's usually when patients have, their quality of life is compromised. That's what motivates them to sign up or to undergo, surgery.
And I think it can also help hit the reset button, as you're saying. Certainly if it's really affecting their quality of life, let alone the mobility of their organs, and that therefore affects the autonomic nervous system, and we see how that affects mental health and brain health. It can, removing all of that just gives the body an opportunity to have a reset, but
Absolutely.
Doing the holistic approach is really necessary to help decrease the endometrial growth from coming back, or endometriosis from growing back, at least as quickly. But really wanting to give them the tools of how to calm their nervous system so they can heal faster, but also connect with a PT, right, to really help retrain those muscles and connective tissue.
Absolutely. Yeah, no, it's a multidisciplinary approach, not just surgically, but in general, just with, like you mentioned, pelvic floor physical therapy. I love my pelvic floor physical therapists. They're amazing. They do a great job, as well as my physiatry colleagues. Because I tell them, look, surgery is the easy part. Surgery is like 2 hours long, 2, 3, 4 hours long. It's easy. You're asleep. You're on an island in Tahiti. You're drinking margaritas during surgery. That's easy. But it's not reasonable to expect that a 4-hour surgery is going to take away 25 years of pain just like that. There has to be some work that's done sometimes before surgery and most of the time after surgery, because it's not reasonable for you to expect to jump off of the OR table expecting to be 100% pain-free. That's likely not going to happen. So yes, with the multidisciplinary approach, along with the physical therapist, my physiatry colleagues, and surgically, urologists, general surgery, colorectal, cardiothoracic, and then you too. We can't ignore the mental health aspect, because that's half the battle too, is the mental part, the emotional part.
That, as well as even just neurologically, right? The central nervous system upregulation, and how the brain changes, and how even the spinal cord changes, and how it receives those incoming signals. All of that needs retrained. Otherwise, the habit is still there and can sometimes reactivate it unintentionally, just because of the neural habits that are created.
100%. Surgery's the easy part. Like I tell them, if surgery's easy, it's all the other work afterwards that they have to do, along with help, that really can give them the quality of life back.
Absolutely. So let's say someone is doing that multidisciplinary approach, right? Maybe they're doing the Retrain Your Pelvic Pain course and learning how to heal their brain and heal the habit of pain. Ideally, they could do that before surgery, so then they're really feeling ready and their system's ready for the most optimal response. But certainly sometimes surgery and giving the body the reset really helps them be able to focus on those other things, depending on, as you said, their quality of life and their high pain levels. But if they're doing that and doing the PT, as well as the surgery, and then working with the physiatry to really help calm down heal the nerves and calm down the nerve reaction, what's average healing time that people can expect?
That's really difficult to predict. From a surgical standpoint, I say, depending on how extensive the surgery was, obviously, most of my patients go home the same day. After the first week, I say you're about 70% back, 60 to 70% back to normal. After the second week, you're about 70 to 80% back to normal. Generally, by the end of 4 weeks, you're feeling pretty good. But honestly, the entire healing time, I say, is at least 6 to 8 weeks. Sometimes it's quicker, sometimes it takes longer. It really depends on the individual, on their bodies, how they heal. But yeah, generally 6 to 8 weeks, but it's a very gray area.
Yeah, I agree. And I would say it's because of so many multiple factors, right? The health of the GI system, any other comorbidities that they have going on. And there's some questions here again of if they've had a hysterectomy or if they have hypermobility or again, other things that would be adding to the agitation of the nervous system. All of that is going to go into, needs to go into consideration of recovery time.
Absolutely.
And retraining it. And I wonder, as far as the role that hormones play, what do you usually recommend that people go on birth control to try to regulate hormones? Do you see that hormones make a difference with endometriosis?
So hormones are a little bit, it depends. Again, it depends on the patient. Most of my patients have already been on some kind of hormonal suppression, whether it be birth control pills, the IUD, the shot, progesterone-only pill. And a lot of times there's been some they've had some, not good side effects from them. And they're like, I tried 30 different birth control pills. I just don't tolerate it. It makes me sick. I get moody. I get, mentally, I just go crazy on hormones. So if that's the case, then, I'm like, oh, well, maybe post-op hormonal suppression wouldn't be a good choice for you, especially if your body doesn't react well to it. I don't want to make you gain weight or be moody or anything like that after surgery. But there's other things that we can try, progesterone only, sometimes the IUD. There's other things that we can try, but ultimately it's going to be a conversation between myself and the patient based on their desires, based on what they're willing to try. I never force hormones on anyone. I do, a lot of times I will make that in my recommendation in terms of I think post-op suppression would be optimal for you, just because there's many different studies that kind of go back and forth between whether post-op suppression really helps recurrence of disease or prevents progression of disease. So I do think that it's nice if you do have a history of painful periods, you do have endometriosis, to do some kind of suppression so you don't have to deal with the period for a little bit, which is nice. But in terms of really preventing recurrence or progression, it's still up in the air. We don't really know. We do know that a good thorough excision surgery the first time around is going to be your best chances of long-term success and long-term relief. And then I think hormonal suppression on top of that, I think it's good if the patient is able to tolerate it.
Yes, and I agree. I've seen both directions, both in the literature as well as my professional experience of following patients both before and after surgery. And I'm biased because I'm I'm a mind body person, but brainiac. But the concept of, again, if we don't get the brain on board, if we don't get the mind on board in order to help calm down the nervous system, you're going to see the recurrence of any type of disease that you're working with.
Absolutely.
Let alone something like endometriosis.
Like you said, if we don't do the whole picture, a lot of times you can have recurrence of symptoms like recurrence of pain, but not necessarily recurrence of disease. So I've done surgeries on patients who've had a history of endometriosis, but they've had it excised, but they start to have recurrent symptoms, go back in, do another surgery. I still take out specimens, but a lot of times those specimens come back negative for endometriosis. And they're like, well, I don't understand because I have an exact same symptoms that I had before, and it was endometriosis before, and now it's not. And so there's a difference between recurrence of disease versus recurrence of symptoms. And like you said,
Yes.
you have to get the mind body on board. So yeah, that's an important point.
Yes, and I love that point, and I think that's so critical with any type of, definitely with endometriosis, and with chronic pelvic pain, and really with any chronic pain anywhere, right? We see that central sensitization, and the parallel I make with it is like phantom limb pain, right? It's like, okay, yes, we cut out.
Yeah.
You know, because people say, well, is it all in my head? And that there's so much stigma about that, and that's so abstract. And it's like, no,
Yeah.
it's literally an electrical program
Yep.
that's in the computer of your whole system, not just the brain. And if we're not reprogramming that system, it's going to keep hitting play. And so one of the things that I include in the Thriving with Endo course is these techniques of not only how to start healing the brain, but also that the bilateral stimulation. Because what we see with chronic pain is in the midbrain, what I say, kind of the bridge is out. There's a quiet, the anterior cingulate cortex really becomes quiet in the midbrain, and that slows down communication between the left and right hemispheres, which increases the stress response, which is also therefore the pain response and sensitization. And so it's to really help give patients the tools they need to kind of help their brain come back online to be able to do some of that updating process.
Tools do you use? That's cool. What kind of tools do you use to help facilitate that?
Yes, so there's music out there that does the bilateral stimulation. I really love Dr. Jeffrey Thompson's music. He's a neuroscientist, and he specifically has created music that has different sounds in the left and right headphones, left and right speakers, that stimulates the brain in specific ways that really helps get, again, kind of the brain online. And so that's usually where I have patients start, because again, the brain hardware that changes makes it really difficult for them to focus on a meditation. So they commonly can't jump into a mindfulness meditation practice because their brain's literally incapable of focusing for that long. And so we start with the music, and then that can lead into two main methods. One, emotional freedom techniques, which is a tapping method, but it's still doing the bilateral stimulation, but you're stimulating natural stress reduction points on the body. So it is activating the amygdala to calm down at the same time as stimulating the left and right sides of the brain, which again is a way to put the brain on manual mode to really help the brain process what's going on. And it's the new magic wand in the PTSD world as far as dealing with trauma.
It sounds like EMDR almost, you know, with
very similar. Yes, exactly.
Yeah.
Yes. Yes. And then one of my other favorite exercises is called brain spotting. And I utilize that a lot because usually with endometriosis or pelvic pain, they've Googled it, right? And they're looking at these really scary images online, or maybe they've seen their own scans of past surgeries or that sort of thing. Yeah. Or a lot of times, because endometriosis can have such a genetic component, right? Almost like generational trauma, it can get passed down. They've seen their mother or their grandmothers in a lot of pain growing up, or maybe they've seen their sisters in pain, right? So there's those images that can be traumatic growing up, but then that also gives their brain that programming of this is what to expect. And so I see that a lot. And so with the brain spotting, you basically take the whatever images that represent pain or their expectation of pain, you take those images and you move it around your visual field. And in the literature, what they're showing that in fMRI scans, if you can, while they're doing this exercise, you literally see the activity of the brain moving back and forth between the hemispheres. And so it's a way to really neutralize those scary images, really neutralize any trauma associated with anything visual that they've seen. So that's a way to kind of really delete and neutralize any of the trauma that they've had, and certainly past medical traumas, in terms of, as you said, so many doctors ignoring them, dismissing them, blaming it on anxiety, blaming it on something else. And there's just a lot of medical trauma I see with pelvic pain, but definitely with endometriosis. I mean, just a lot of dismissal.
For sure. Wow, that's cool.
Yeah. So
that one-on-one usually with your clients? I
can do one-on-one, but I kind of go over in a quick way in the Thriving with Endo course. I'm saying, here's the exercise. You can look it up on YouTube and explore it. If you want more information, either have a one-on-one with me or do the Retrain Your Pelvic Pain course. And then I also go through practical applications, right? Okay, make sure you know how to get to where you're going. Where do you have a safe place to recover? Do you have a safe driver? Also, I talk about the anti-inflammatory diet for, try to get them to do that a few weeks prior to the surgery. So they're decreasing inflammation prior to going into something like a surgery. And the literature shows that they can heal faster from any surgery if they really decrease inflammation. So it's a mixture of kind of skills to calm the nervous system as far as the bilateral stimulation, the breathing exercises. I talk about hypnosis and visualization, right? Visualizing what healing looks like to really help their system. But then I go into practical applications during the course.
Okay, amazing. Yeah.
What have you heard from patients as far as that you've done surgery on or communicating with that have they taken, those that have taken the course prior to surgery? Are you noticing a difference at all?
I've gotten really good feedback from them, just in terms of, I think it's just validating for them to sit down on a how long is it, like an hour course?
Yep.
And it just validating that they have chronic pelvic pain, that they know that someone else understands, and there's other women there going through the same thing, and it's not just all in their head. And I do feel like it's highly beneficial preoperatively.
Yes, I mean, so does it feel that they feel more prepared for the surgery and kind of just knowing what to expect? I mean, I know you spend a lot of time with them to answer their questions.
No, I feel like they feel pretty prepared in terms of the technical aspects of surgery, what to expect, blah blah blah. But in terms of, for instance, going into the OR can be very scary for them. And I know some patients have said, just practicing some of the relaxation techniques and trying to reduce their anxiety, because that's really scary for anyone. So I know that there are patients who have found a lot of benefit in utilizing the tools that you provide for them during that course, which makes my life easier.
Great.
Yeah.
Let me ask this, and I'm thinking I probably should have talked to you about this prior to recommending it to patients, but I recommend that they put on a 3x5 card 1 or 2 statements that could be read to them while they're going under anesthesia, as almost because we know that when they're going under anesthesia, we're very suggestible, right? So something like, you're in safe hands and everything's, this is going to be a successful surgery, or you're going to heal quickly, or they choose the statements. Has anyone brought that in yet, as far as asking the?
Not that I know of.
Not yet. Okay.
Yeah.
Is that what do you think about that?
We will ask, what music do you want to listen to as you go to sleep? Like, what kind of music do you like? Or when I'm with the urologist, he'll make these awful dad jokes, when they're going on. Or like, we try to keep it a very light experience, because it is very, very scary. But yeah, I mean, the 3x5 cards are totally fine. I think that would be great, especially if that's something that would bring them more comfort. 100%. 100% should do it.
I love that you asked them what music to play. I mean, music can be so perfect in calming the nervous system. I mean, we know that the nervous system actually matches whatever sound frequency is around us, which is cool. There's actually a fun new gadget called the Apollo device that utilizes sound frequency, but it's a wearable, and you can literally kind of channel your nervous system of where you want your nervous system at.
Wow.
Yeah.
Wow.
The fancy gadgets.
Yeah. Cool.
Yeah, so I'm just gonna kind of check my list here. So we talked about the thriving with endo. We talked about kind of endo in general, and we've answered a few of the questions online that have come through. One of the questions that also came through was there's when to seek physical therapy. Like how long after having an excision surgery do you recommend that they return to PT?
Well, I usually say 6 to 8 weeks. If you've already established yourself with a good physical therapist before the surgery, I've had patients email me and be like, "Hey, can I go see Dr. So-and-so? And it's only been 2 weeks." I'm like, "Sure," as long as they understand that, you just do some external light physical therapy, nothing hardcore. And if I know the physical therapist, I'm like, "Sure, no problem." They get it. They'll understand. But if you're just starting out with physical therapy, a lot of times I'll say wait maybe 4 to 6 weeks, depending on how you're feeling. Again, everyone heals differently, so it depends.
Yeah, I would agree, because we want to let the body heal, but we also want to make sure that we're helping guide the body where we want that scar tissue or connective tissue to how we want that to form.
Exactly.
As far as let's see, with healing the brain and kind of mental health, I'm having a brain fart, right? I had a thought and it's gone.
Happens to me all the time. I start to drop a little bit, so.
Is there anything we haven't mentioned? I mean, I guess to certainly making a consultation appointment, they can call Pelvic Rehabilitation Medicine and talk with you. I mean, everyone, I know all the patients that have utilized you for the excision surgery only have amazing things to say of how you're available and how you really talk to them over the phone and really calm their nerves. But again, you know, that our integrative and interdisciplinary approach is just so important to highlight with these patients.
Absolutely. Yeah, no, this is a team effort. It's 100% a team effort. And like I said, pelvic pain is like a giant jigsaw puzzle. Surgery may be a part of that, you know, maybe a piece of the puzzle. Physical therapy may be a piece of the puzzle. What you do is a piece of the puzzle, and there's physiatry is another piece of the puzzle. And with all of us together, we kind of can make it whole again. Because if you just do surgery and that's it, you're not going to get, you'll get some results, but you're not going to get optimal results. And I really want my patients to get optimal results. And I know that I am not enough. I'm nowhere near enough for that to happen. I need help from people who are way smarter than me and who, you know, for instance, what you do is, I mean, it's fascinating to me. There's no way that I would be able to provide the kind of support that you do for my patients. And I think what you do and what I do are equally important in patient well-being and, you know, whole person care, as well as psychiatry colleagues do, what my physical therapist colleagues do, and we really have to start looking at the patient as just a whole person. And I'm definitely not enough to fix anything. I can help put one of the little pieces of the puzzle back together, but that's it.
Right. It takes a team. I mean, sometimes I'll use the metaphor of it's building a house, right? You need the main foreman that's overseeing the whole project, ideally. But, you know, we've got the carpenter, and then we've got the plumber, and then we've got the HVAC guy and the roof guy. And I think about that. Just my husband's a contractor. So what are all the different metaphors we can use? A metaphor that the Australia Pain Group utilizes is an orchestra, right? There's an orchestra in the brain, but then there's an orchestra of the whole of the whole treatment team. And I think what I love that PRM really does is give the patients informed consent that says this is a piece of it, but if you're not doing these other pieces, the nervous system is going to go right back to where it was, and you're going to have, you know, the domino effect that happens with the upregulation of the nervous system. Yeah. Great. So let's, I guess, to summarize, if those listening in can contact PRM to have a consultation with you. Ideally, they're also going to, you know, we can get them signed up for the Retrain Your Pelvic Pain course, so they can really learn how to reprogram their brain to help decrease, their pain, but also decrease systemic inflammation that can really lead to the regrowth of endometriosis and the regrowth of really inflammation anywhere. And then anyone that is signed up for surgery can attend the Thriving with Endo course for free. Which is awesome and exciting, and just getting as much information and resources that we can offer. Yeah, no, I said it perfectly. Awesome. All right. Well, thank you so much. This is great. I wish I lived in New York so that way we could see each other more often. But, you know, again, everyone listening in, we all work together and we're a team, and it's an amazing team at PRM, and we all really understand the importance of each aspect of what we do. Oh, and we do have a new nutritionist on board. So she's gonna be, so her name's Monique, and she's gonna be really helpful at helping patients learn how to, one thing I talk about the Thriving with Endo course is preparing meals, so you don't have to worry about cooking the first week or two when you're recovering, but also the healthy meals, right? How to really help keep the anti-inflammatory diet focused, so that way they heal, you know, the body heals faster. So we now have a nutritionist that can help figure out what that looks like. That's cool. Yeah. All right. Well, everyone, thanks for joining in. Thank you, Dr. Liu, for your time, and hope you have a wonderful day. Yeah, we'll just get some time fun. Bye. All right. Bye. Have a good one.